Good morning. I'm Molly Galvin, Media Officer for the National Academies. I'd like to welcome those of you in the room and those watching our live webcast to the release of a new report, Graduate Medical Education That Meets the Nation's Health Needs, from the Institute of Medicine. The report and related materials are now available online at www.iom.edu and at nationalacademies.org. This will be a one-hour public briefing to discuss this new report. After some brief introduction of the committee members who have joined us today, our panel will provide you an overview of the report's key points. Then we will open the floor to your questions. We ask those of you in the room to step to an aisle microphone to ask your questions. Webcast viewers can submit questions at any time during the briefing using the online form. We ask everyone to be sure to identify yourself by name and organization when you ask your questions. IOM is tweeting about this event. You can join the conversation on Twitter using the hashtag IOMGME. And now I'd like to welcome Victor Zhao, President of the Institute of Medicine, who will introduce our esteemed committee members.
Well, good morning and welcome. I'm the president of the Institute of Medicine, and I thank all of you for attending this release. You know, this, in fact, is the first public report release during my time at IOM. And I'm very pleased to be here because to really, in many ways, see this, the final stages of very important work done by a very knowledgeable committee. This is a topic, of course, on graduate medical education, something that's certainly dear to my heart. I think it's clear to all of us that as our population ages and chronic conditions become more prevalent, we have to produce a physician workforce, a provider workforce, that can meet our population needs. For decades, Medicare has been the major funder of GME and has been incredibly valuable to the success of training programs across the country. So I would say that I'm one of those beneficiaries of that support. However, I think we all recognize that maybe today's GME program or system needs to do more to meet today's needs for a high-quality, patient-centered, affordable care. And there are many issues I think we have to tackle with. Certainly, there are not enough physicians in certain specialties. There are not enough physicians in primary care in certain geographic areas and community-based setting where most Americans receive their care. So today's system needs to be better equipped for learning and adapting. And it really needs to do a better job in tracking outcomes, rewarding performance, and responding flexibly and quickly to problems that arise. I think we all agree that medical education, in this case GME, has to be modernized. It needs to be more relevant to today and tomorrow's needs and needs to be more innovative. So to address this problem, in fact, the Josiah Macy Foundation and President George Thibault is here with actually an organization that I was on the board and chair of, the Association of Academic Health Centers, held a meeting in 2010 in October, and they called for an independent external review of the governance and financing of GME, specifically suggesting that IOM perform this review. With the support of 12 private foundations, and I think I have a slide to acknowledge all the sponsors, and we can put that slide up. Well, I guess I don't have one. You can have me read the 12, or you can assume that they're all great people, but let me just make sure that I do acknowledge them because I think they put a lot of effort into it. But also 12 U.S. senators. IOM formed a committee to analyze the governance and financing of the GME system. So the sponsors, since I don't have a slide up, I do think they should be recognized, are ABIM Foundation, Aetna Foundation, California Endowment, California Healthcare Foundation, Commonwealth Fund, East Bay Community Foundation, Health Resources and Services Administration, HRSA, Jewish Healthcare Foundation, Josiah Macy Jr. Foundation, Kaiser Permanente Institute for Health Policy, Missouri Foundation for Health, Robert Wood Johnson Foundation, United Health Group Foundation, and U.S. Department of Veterans Affairs. Now, the committee, Knowledge Committee, is really ably led by our co-chairs, Don Berwick and Gail Walensky, who's here today, and is made of 21 members. And two of our members are here, Deborah Powell and Deborah Weinstein. The committee did a super job in going through some very difficult issues, and unfortunately I didn't have the privilege of being engaged with it because this was done during my last predecessor, but certainly I think that many of the recommendations and the principles I think we need to pay a lot of attention to. The committee work is supported by a team of IOM staff, Joe Eden, who's a study director who's here, Kyla Watkins, Hannah During, Sarah Thurikan, Celine Balatbat, and Katie McGee. I'd like to thank the committee and IOM staff for their dedication to improving the state of our nation's medical education and hard work they put into the report. So, the committee and staff produced a report that suggests modernizing the current GME system to become more transparent, more accountable, strategic, and innovative. I certainly concur with those principal directions. As I said, I didn't have the privilege of being involved with the study, which was completed before I arrived, so I'll leave the discussions of the details recommendation to committee members themselves and the committee members who have joined us here today. First, I certainly want to thank Gail Linsky, co-chair of the committee. I think all of you know her well. She's an economist, a senior fellow at Project Hope, and former administrator for the CMMS. Deborah Powell, another person I've greatly admired, Dean Emeritus and Professor of Laboratory Medicine and Pathology at the University of Minnesota Medical School in Minneapolis. And of course, Debbie Weinstein, whom I've known for a long time, Vice President for GME at Partners Healthcare, a system in Boston. So I'm going to turn the podium over to them, Gail, Deborah, and Deborah. Thank you really so much for your really hard work and your thoughtfulness in working through this very difficult and I would say important issue. And I would just hand over the microphone to you right now. Thank you very much.
Thank you, Dr. Zhao. I'd like to acknowledge one other committee member who's in the audience, Dr. Fitzhugh Mullen from George Washington University. As you heard, this was a large and very distinguished committee, and also an individual who is here today who was present during the first part of our study, Cheryl Ulmer, and to thank her for her efforts in getting this off the ground. I'm going to briefly summarize what we looked at, why we looked at it this way, and what our recommendations are, and then ask my two committee members on either side of me if they have some brief comments before we open it up for questions and answers. As you heard, this is neither the first study of graduate medical education, and we tried to look at the issues, recognizing the work that had come before us. We had been charged with reviewing the financing and governance of graduate medical education and making recommendations for improving graduate medical education, but to do so particularly being mindful of the type of physician workforce that needs to be present in order to deliver efficient, high-quality care. In attempting to go about this task, we thought it was important for us to inform ourselves of what the various previous commissions had concluded, particularly the two most recent conferences that the Macy Foundation had sponsored. We were fortunate to have some physical presence reminding us of those activities, but we reviewed them as well as other studies that had occurred before that, and were struck by the fact that certain conclusions had seemed common to most of the previous committees. One of them is that attempting to forecast specifically physician future shortages is extremely difficult. The results have typically been unreliable. They have varied in magnitude greatly. In fact, in some cases, they haven't even been directionally correct. Shortages predicted when a surplus, in fact, resulted. It's also been quite clear to many of the predecessor committees that increasing the physician workforce per se is not a likely way to resolve important issues with regard to either specialty or geographic distribution. One that we focused on and that some but not all of the previous studies have commented on is the disjointness between the Medicare funds that were available for GME training and the actual number of trained physicians undergraduate medical education. It became particularly noticeable given the cap on Medicare funds that occurred as part of the Balanced Budget Act in 1996 and the increase in the number of residency slots that continued after a brief several-year hiatus. This is an issue that we returned to comment on and to incorporate into some of our recommendations. It's also been noted that despite concerns about the increasing specialization of the physician workforce, it has continued becoming increasingly specialized. And finally, a number of reports have noted that some of the newly trained physicians are not very well equipped for ambulatory care, even though that's where most of the care is currently being provided in the United States. Unlike some of the other committees that came before us, we took a step backward in beginning our discussions and talked about why it is that either Medicare or the federal government at all is involved in the financing of graduate medical education, noting that it's a quite unusual role for the federal government to occur compared to its lack of involvement, say, in the financing of undergraduate medical education or in other health professional areas or in other professions that are regarded as important to society and in some shortage, and had rather extended conversations about the appropriateness of the federal government role in graduate medical education, lasting until our very final meeting. In the end, we thought that the type of changes that are now being experienced by the healthcare delivery system as we move from a volume-based, cost-based reimbursement system to one that is focused on value and which we hope will become a high-performing healthcare system where efficient care is provided at lower costs, that Medicare, the major funder of graduate medical education under the federal government, could play a very important role in terms of leveraging the type of change that is needed. When we had looked at the current federal financing, we were struck by the components of that federal funding. As I've mentioned, the largest single piece is Medicare. Out of the roughly $15 billion, it accounts for just under $10 billion. And the second biggest piece is Medicaid, which is just under $4 billion. The two other significant or important components are HRSA and the Veterans Administration. But the largest, clearly the dominant part, was what comes from Medicare. And it was that really where we focused. And our view was if we were to continue with recommending the funding of graduate medical education using Medicare resources, we needed to have it be redesigned and repurposed in order to help develop the physician workforce we thought appropriate for the 21st century. Some of the findings that we had that informed the recommendations that we made, which I'll get to in a minute, are that the current use of funding under Medicare is based on rigid statutory provisions that are at least 30 years old. Most of the changes occurred in the 1980s, both the baseline for direct graduate medical education in 1983, and then the introduction of the concept of indirect medical education with the introduction of the DRG payment system also in 1983. And that these rigid formulas don't really reflect either the current context in which healthcare is being provided or are serving current needs very well. There is inherent explicit reliance on a cost-based reimbursement model, even though Medicare has been attempting to move away from cost-based reimbursement, and importantly starting with the DRG system, but extending it to physician payment and nursing homes and home care in the 1990s. It is heavily tied to inpatient care for only Medicare patients, even though all patients are affected by the training of graduate medical education. And as I've already mentioned, care is increasingly moving out of the inpatient setting. Not that the inpatient setting doesn't remain important for some of the complex medical procedures provided, but both because of the development of new technology, the preference for many patients, increasing amounts of care is being provided outside of the hospital in an ambulatory settings. We were struck by what I frequently term as a peculiar distribution of funding that has resulted these historic inequities and what appear to be inequities in terms of the distribution of funds follow the statutory provisions that were in place, but don't seem very well suited to meeting the needs of this 21st century healthcare that I've mentioned. Unlike most of Medicare, it has no link to outcomes. Medicare is still in its early stages of attempting to move to a performance-based system. But basically, everywhere you look in Medicare, other than graduate medical education, you see the beginnings of this happening with value-based purchasing in hospitals and starting in nursing homes and home care, the value modifier that is in place to be used for physician payment in the next couple of years, and in general the emphasis on moving to a value-based system when we get around to reforming physician reimbursement, which maybe will happen in the next year. It was also clear to us that the financial impact of sponsoring residency programs by teaching hospitals and other institutions is not well understood, and the whole process, in fact, needs to have greater transparency and accountability. We talked about governance a good deal. A number of the committee members, Dr. Powell in particular, have spent substantial parts of their professional career focused on governance and accountability in the accreditation process, and we were struck by the fact that there is an absence of transparency in the current system, that basically the only gating mechanism that currently exists to receipt of the funds, other than having historically had the basis for receiving funds, is that the program be accredited. And while we think that accreditation plays a very important role in terms of assuring quality of the physicians that are produced in a clinical setting, we don't think it is appropriate to look to the accreditation process in terms of helping to meet the needs of the nation in terms of the types and distribution of physicians that are produced. As a result of the current mechanisms, there's no group that is really accountable or responsible for looking at the specialty mix that is produced and trying to see whether or not it makes sense in terms of the needs of the population. We weren't suggesting that the accreditors should be assigned this task, but we noted that in any case it wasn't being done by them, and there wasn't really any other group that had this as an overall responsibility. As a result of these findings and of the conclusion that we had come to, which is given the amount of change that the healthcare delivery system is undergoing, that the Medicare funding could provide key critical leverage to help produce the physicians needed to be a part of the healthcare team workforce of the 21st century. We concluded the importance of keeping, at least for the immediate term by which we identified as the next decade going forward, Medicare funding provided a series of recommendations that are in the order of what we're suggesting, were adopted in order to try to repurpose and reposition the use of Medicare funds and to make it more transparent and more accountable in terms of how these funds are used. Specifically, we've made 5 recommendations. The first is that we maintain Medicare funding at least for the next decade, adjusting the amount for inflation and looking at the combined amount of direct and indirect medical education funding. That we gradually move to a performance-based system, and that while we do that, we phase out the current system. One of the themes that we have articulated in our report and all strongly embrace is the importance of a phase into a new system, recognizing that institutions need some amount of time in order to adapt to change, and basically following the precedent that Medicare has used in the past when it has adopted new payment programs. It typically have used 3 years of a blended payment, a base year to start, and a final year to achieve the change it has been attempting to seek. That was true for the DRGs in the 1980s. It was also true when the relative value scale was adopted in 1992. We think this concept of phase-in is important and reference it several times in our report, recognizing that institutions need this adoption time. But we think that moving ultimately to this new system, particularly one that's performance-based, is critical to justifying continued use of public funds. We are recommending a specific policy and financing infrastructure that we do not believe currently exists. We are recommending a Gme Policy Council be established in the Office of the Secretary of HHS. This group is modeled after Medicare Payment Advisory Commission, in that it should be made up of a number of individuals reflecting certain expertise. We've recommended a somewhat smaller group because the amount of money at stake is considerably smaller than all of Medicare. But the idea that there be a combination of expertise, that it be a minority at most of stakeholders represented, and that there be terms that are used for the individuals, we thought is a good model. That the responsibilities would be to develop a strategic plan for GME funding, to sponsor some of the research that would be needed in order to deal with these difficult issues of the type and mix of physicians needed for the future, recognizing that answer to that depends a lot on who else is providing services, what other kind of healthcare professionals, and what kinds of technology they have available, such as telemedicine or clinical decision supports. And one of the most important functions of this policy council is to serve as a coordinator between other federal agencies involved, the National Health Service Corps, among others, and the accrediting and certifying organizations, which we think will continue to play a very important role and want to make sure that there is an active coordination that goes on between the Policy Council and the accrediting and certifying organizations. In addition, we're recommending that there be a GME center established within CMS. This is still involving the distribution of Medicare monies. It is important and appropriate that CMS be involved in that. Most of the activity we assume would be part of a CMS center specifically for this purpose, but we also are hopeful that there would be active collaboration with the Innovation Center when it comes to evaluating some of the innovations we hope will be supported with one of the funds we want to see established. The third recommendation is to create a single Medicare GME fund, unlike the two funding streams that now exist, direct and indirect medical education, but to use two subsidiary funds, one of which, the one that will represent the dominant amount of money, is the operations fund, and it will be used to support residency training for positions that are currently approved and funded. A second and smaller in magnitude, but critical to our view of change for the future, is a transformation fund, which will be used to finance initiatives that will develop and evaluate innovative GME programs. Some of these will be at the research level in terms of developing the kind of performance metrics that will be needed if we're to move to a performance-based system. There's been a lot of work in this area in general of performance metrics, but there has not been nearly so much in terms of educational and the training of physicians. We think this needs to be started very quickly if it's going to be adopted within a 4 or 5 year period. We want to have the innovation, the transformation fund, be the place where alternative GME payment methods are piloted. We were intrigued with the notion of a voucher program where the money follows the individual, which is more normally what happens in subsidy and sponsorship programs, but has not been the case with residencies. But we recognize that we really don't know what would happen with such a program. This needs to be piloted and evaluated. And most importantly, we are using the Transformation Fund to award new Medicare-funded GME payments for priority specialty areas and priority geographic areas that have currently gotten short shrift in the distribution of Medicare funds. We are assuming at the start a distribution that's in the nature of 90% of the money in the operational fund, and 10% in the transformation fund, that would increase over time in the decade as more pilots and initiative came in, and then probably as they were ready to move into full operations and be a part of the full program, that more money would move back to the operational fund. But we recognize these are general magnitude suggestions as opposed to precise movements of change, either in terms of the specific dollars for each or in the timeline that we are recommending. We have, as I've indicated, recommended that we put the two existing funds together, indirect and direct medical education, with one payment to the organizations that are sponsoring the GME programs, and that amount move again over time to a national per resident amount, which is adjusted for geography. very different from what the current system is, both in terms of the use of a single per resident amount. Equally important, very different in that money goes to the sponsoring organization and not to the teaching hospital per se, irrespective of where the sponsoring organization lies. We would start with having the per resident amount equal to the total amount of the operation fund divided by the current number of residents that are in Medicare funded slots. Since we are assuming about 90% of the money adjusted for inflation over time, that means some haircut to existing recipients so that some amount of money can start to be used for innovation, initially probably focused on setting up the infrastructure, and that as we move over time, performance-based payments using information from the Transformation Fund pilots would be adapted directly into the operation funds. Finally, we have recommended that Medicaid continue to exist at the discretion of the states in terms of using Medicaid funds for graduate medical education. We think that principle ought to be maintained in the future, but we also think that the accountability and the transparency standards that we are recommending for Medicare are equally important for Medicaid in terms of being the responsible steward for public funds. So in short, we are recommending, after very substantial discussion about the rationale for continued federal funding, that Medicare funds over the course of the next decade be continued in supporting this very important process of helping to train the workforce needed for a reformed 21st century delivery system. We recommend that toward the end of the decade, an additional assessment be done evaluating the results of this change and whether or not there continues to be a rationale for further federal funding going forward, and that by doing this, we can both help train the physician workforce for a 21st century and feel that we are advocating the responsible use of public funds going forward. Deborah, any words? And I will ask the other deputy.
So just a couple of things that I thought I might add to Gail's comments. One, we felt that a very important early use of the Transformation Fund, which would start out at about 10% of the total amount, would be first to establish the governance structure, which we feel is essential in order to have two entities that oversee a new financing model. And secondly, to transition the Children's Health Center GME programs and the Teaching Health Center programs that are currently in HRSA and funded by appropriations into the regular GME funding stream. And these would be important uses initially of the Transformation Fund so that those two outliers could be put into the regular GME programs.
Thank you. Gail did a beautiful job of summarizing a very complex report and set of recommendations. I'll just try and emphasize a couple of things. First is there are some short-term activities and some longer-term activities that we're proposing. The short-term, as Gail explained, involves improving the payment methodology in ways that will address some existing inequities. The longer-term involves moving from a cost reimbursement-based payment system to an outcomes-based payment system. And that gets at this idea of strategically investing in GME so that we can identify the national health outcomes that we think are important, clarify what those outcomes are very explicitly, develop metrics for measuring them, and then tune the payments toward those outcomes. All of that's going to take some time, it's going to take some research, and we have a huge amount of optimism for what this Transformation Fund can accomplish. So we hope that there'll be a lot of activity in developing demonstration projects and pilots to use those funds. And much of the funds spent on transformation projects will be at the institutions now sponsoring GME. So to the extent that certain funds are taken out of the operational pool, they may in fact go back to some of the same sites, just in a different way toward a very specific purpose. Lastly, I just want to acknowledge some of the limitations of our work. We recognized a number of times through the process that GME is critical. It's a absolutely essential element of our healthcare system and resource for our healthcare system, but it can't alone fix our healthcare system. And some of the problems that we identified need other solutions outside of GME. In addition, given as broad as our scope was, our scope didn't include looking at some of the problems and potential solutions that cross the different span of professional development, UME, GME, continuing professional development, and that span the health professions. We were limited to looking at the development of physicians. So those are other questions that other groups can continue to work on. Thank you.
We completed our part of the presentation.
Thank you. Just a reminder to step to the aisle microphones with your questions, and we will also be taking questions via webcast, and you could submit those online.
Danny McCory, Heritage Foundation. Many people are concerned that the amount of money residents are making themselves is insignificant compared to other people of competitive degrees of equal caliber. Does your institute suggest anything to address that?
Actually, what I would like to suggest is that you read a perspective in the New England Journal that Amitabh Chandra from Harvard, who was also on the committee, and I wrote explaining how economists view the salary that you see. It is correct that it is an unusually low salary given the sophistication of the people who are being trained. What you are seeing is the net flow of funds reflecting the cost of education received and the value of services provided that is averaged out over the years of training and across specialties, because institutions have traditionally done it that way. So you should not think about it as this is the salary that residents are receiving, but rather it is the net exchange, which could have been you pay a tuition as you do for undergraduate medical education, and they pay a different salary for the services you provide, and you get a net result that we think, on average, across specialties, across years of training, would probably look about where it is now. So it really needs to change the context.
Thank you.
Dr. Richard Rieselbach, University of Wisconsin, School of Medicine and Public Health. Your plan is perceptive and comprehensive and clearly very needed. My question is, it's gradual. What do we do about the next couple of years when the VA problem has been described as a canary in the coal mine in terms of primary care shortages? And is there a suggestion for immediate action in the next couple of years?
The short answer is no, because the nature of training graduate medical education physicians is the timeline is substantial. Outside of our report, my response would be there may be more scope for change if we look to healthcare workers outside of physicians and think about how they can be used more efficiently and effectively. Some of that may require scope of practice changes in law, since they vary dramatically across the country. and the adoption of productivity-enhancing technologies substantially more than has occurred now. The nature of producing physicians per se is that it's hard to do things on the quick because of the time of the undergraduate medical education and the graduate training. We, as I forget which of my Deborah's mentioned, recognized that somebody needs to look at the length and scope of training of undergraduate medical education. We were looking at the tip of the tail of the dog by focusing on graduate medical education, but recognized it was beyond the scope and expertise of the people in the committee. But I think realistically in the short term, it's going to be how do we make smarter use of the resources that are out there than we currently do, some of which will require change at least at the state level in terms of allowing that to happen.
Hi, Gail. I'm Dr. Janice Orlowski. I am the Interim Chief of Healthcare Affairs at the Association of American Medical Colleges. The AAMC, first of all, wants to thank the panel for the work that they've done, very comprehensive work, and I think it's a very important subject for us to be involved in. Second thing is we'd like to say that we wholeheartedly support and have made efforts with other organizations to increase the accountability for the GME finances, and we completely support that aspect of your report. There's three areas that I want to raise concern about. The first is that as we take a look at the current training of physicians in America, it is thought to be a very robust system. And we actually see nations around the world sending their individuals to our training programs because they're seen as the best in the world, their highest quality, and really producing fine physicians. We agree with you that there needs to be levers in order to direct both geography as well as to take a look at specialties. But the concern that we have, and I do want to go back to one of the comments about the VA, is the canary in the coal mine, that there's no comment at all having to do with the numbers of physicians that are needed as we have a large aging population that will require not only primary care physicians but also specialty physicians. The second issue that I would wish for you to address is the issue of the Ime Payment. The Ime Payment was never meant to be a direct payment for the residents, but rather the Ime Payment was meant to support the hospital and the teaching environment in which the physicians train. You know that right now those IME dollars support the training environment, which includes not only the primary care programs, but also supports the burn centers for all of America. It supports the trauma centers. It supports those programs that, quote unquote, don't make money but need to be present for those that be training, whether it's large diabetic programs, whether it's the continued, increase in heart failure programs that are needed. So as I take a look at your report, I don't see that the support that has been provided for IME, I don't understand where that has been addressed in the report. And I think the I said three, but I'm going to stop with two right now. I think those probably are the areas that raise the most concern as we take a look at this. And again, believe that there's important aspects that we can work on that come from the discussion that we're having, but want to raise the concerns that these issues have not been addressed.
I'd be happy to address your first point, concern about predicted shortages. So as Gail mentioned in her overview, we did look carefully at the various predictions. Most of them point towards shortages, though not all of them. We're concerned that many of these predictions rely on assumptions of stable provider-patient ratios, which we think should be updated. We need to project based on the changing roles of different types of providers, the increasing importance of team-based care. So that makes it even harder to predict. We absolutely agree that there needs to be sufficient access to care. And in order to achieve that, there needs to be reliable data, ongoing monitoring and research, and a Gme Policy Council that uses that information and helps to tune the funding distribution toward those particular outcomes. We also noted that just adding more physicians is not going to sufficiently address the maldistribution in terms of specialty and geography that we're now seeing. And adding more money may not be necessary in terms of a one-to-one relationship because, as Gail mentioned, we've seen over the last 9 years in the face of a Medicare cap for the number of funded GME slots, a 17% increase in GME slots. And then finally, the transition fund, as we've described it and proposed it, does have the ability to fund new incremental slots in needed areas.
Say the economists on the committee were even stronger in their views that attempting to project the number of physicians needed, given the different ways healthcare can be provided, depending on how you mix and match the skill sets and the care needed, makes it not very useful to try to come up with the specific projected needs. We look around at the VA and the military, and the Kaisers and the Geisingers of the world. We see very different mixes used in terms of specialty versus primary care, but also in terms of physicians versus other healthcare professionals, and we suspect there's a lot more imaginative strategies that can be used than those. They just give us some idea about the kind of variation that can be used to produce quality healthcare outcomes, and that doesn't even begin to look at the kinds of technology that are or we believe will be available during the time it takes to produce a specialty trained physician, which is a decade or more, that would allow for other extensions and increases in productivity. So we think it's an important issue, which is one of the issues we think the Policy Council can look at, but we were not, as a committee, willing to buy into the notion of any particular projection, or even to buy into the notion that there is a clear shortage coming in the future because of the aging of the population, although there may have been some difference of opinions based on professional background diversity. With regard to the second issue, the IME, this is a deeper philosophical issue that goes to the comment I made about moving away from cost-based reimbursement. IME as a concept basically says there are higher spendings that have been observed per Medicare patient treated after every accountable variable has been able to be included. And that's what, on average, the Ime payment has been for. And in a cost-based reimbursement system, that makes some sense. In a value-based reimbursement system, the answer should be better value is being provided, and that's why we are paying additional monies. And we are okay with that kind of a performance-based system, and we are allowing for the money to be present in order to allow for improved payment because of improved performance and value provided. We are not, as a group, willing to continue the notion of paying more because you spend more or it costs more. It's not even clear whether it costs more. It's really clear that more is being spent after every variable has been able to be included. That seems reasonable, and spending more and costing more aren't always exactly the same thing. So we just rejected the fundamental basis, although again it was probably reflecting different views depending on our professional associations, and we also noted that one of the justifications historically for higher payments for academic health centers has been the large number of uninsured that have been traditionally treated, and that hopefully as the Affordable Care Act goes forward, that will substantially be reduced, although not in its entirety. So we just think if there is a call for having specific payments to cover areas that are regarded as not sufficiently reimbursed, it needs to be explicit, and doing this as we can't explain what this is for, but we're going to give more money because on average more is spent, was not consistent with the movement to a performance-based system that we are trying to help the healthcare delivery system move to.
I appreciate your responses. So the idea that there is a physician shortage is something that was entertained by the committee, but not a specific recommendation for that. And then
it wasn't.
It wasn't agreed to.
Mm-hmm. It was entertained in terms of discussed, and I think you will see in the report, there is some discussion about the issue. There was not a consensus agreement that there is a shortage going forward.
And I think the other question, which I think is interesting of your report, is that we have our Medicare funding, and the suggestion is that those Medicare dollars be taken, and at the current time they're based on a percentage of Medicare patients that are treated. So it's meant to be a direct relationship. And you're suggesting that those payments be taken and that they be spread across all patients, regardless of payer source. And I was wondering if you could make some comments about that. Thank you.
Yes, that is clearly what we are recommending. That it recognize what I think many people have recognized all along, which is that the people who are being trained as graduate physicians treat all individuals, not just Medicare patients. That's been true from the get-go. We discussed the origin of Medicare funding that occurred in 1965 for graduate medical education. We considered whether other funding might be more sensible and appropriate. It certainly is possible to imagine a direct appropriations system of funding that could be used instead of Medicare. But we concluded the reliability and predictability of Medicare is so important to graduate medical education that it effectively trumps all other funding sources that we could consider, and therefore in the sense that Medicare funding has always primarily affected all people using the healthcare system and not just those on Medicare, that this is a better way to make use of those funds, benefiting the public in terms of a more accountable and transparent use of public funds.
We now have a question from the web. This question comes from Julie Cantor-Weinberg. She's the Director of Economic and Regulatory Affairs at the College of American Pathologists. She wants to know, how would the recommendations treat diagnostic specialties?
Would you like to take that? Being our resident pathologist.
Sure. I think the recommendations apply to all specialties, and I think the recommendations that we're making apply to all currently funded training slots, which include hospital-based specialties as well as medical, surgical, and primary care specialties. We also recommended funding using the same formula, namely that primary residencies be funded to 100% and the fellowships be funded at 50% as they have been.
Tom Ricketts from the University of North Carolina. A little, let's say, not taken aback, but just worried that the committee felt that projections and anticipating the future of supply and need was such a difficult thing that it couldn't be done well. I think it can be done well if it is done with the consideration of options and alternatives, as you said, and that can be done now. And I would recommend the committee has finished its work, but to the readers and other folks interested in this, the Physicians Foundation will release an online model tomorrow that takes into consideration multiple variations in policy, both payment, construction of teams, as well as funding of GME, and that we might support the work of our economist friends who are doing this kinds of projection, as long as it is done in a way that is fair and understandable and takes into consideration all of these variations that we're talking about. Thank you.
Let me just clarify, because I don't disagree with what you have said. For purposes of our report, there was no particular single projection of either a shortage or a shortage by specialty that would be applicable a decade or two down the road that we thought would inform our decision making. Rather, we looked to the Gme Policy Council as an ongoing group that would be used to direct additional funding in areas that are appearing to be in shortage and would be a better way to evaluate or make use of the ongoing estimates of where there are shortages or surpluses potentially in various areas. So not that it can't be done, but there was nothing that would really help us in moving forward that we thought was out there. So it was more of, for us, trying to make a specific projection. We weren't willing to buy in. There was a clear shortage that we could project as of 2025 in something.
Hi, Marcy Nelson from the Physician Assistant Education Association. What role does interprofessional education, so physicians working with PAs and others, play in the Transformational Fund?
Well, this was the area where we attempted to recognize that the change delivery system we and others have envisioned involves healthcare teams, and that healthcare teams mean helping to train physicians to work in a more coordinated way with other healthcare professionals, including physician assistants, and that some of that support could come out of the Transformation Fund to both pilot activities encouraging that interdisciplinary activity and evaluating the effectiveness of various. So it was in the Transformation Fund. We discussed whether we should more broadly consider this and decided that the monies we had were sufficiently limited and our charge was sufficiently directed toward physicians that was how we should deal with it.
Henning Schroeder, University of Minnesota, and currently at the National Science Foundation. You talk about performance-based allocation of funds and educational outcomes as a basis for allocation. I would be interested in finding out if the committee has some thoughts on what kind of metrics would be used for that. Would it be placement record, or what would be appropriate metrics for residency programs as opposed to PhD programs, for example?
Yeah.
Thank you.
Sure. And this is why we need some time to get from here to there, because we first have to define what are the important outcomes, and then we have to figure out what are the metrics that will responsibly measure those outcomes. So I think everyone would agree that what we're aiming for is graduates who will deliver high-quality, cost-effective care. So to some extent, the performance measures might be the health outcomes of the patients who are taken care of by our graduates. So that outcome might be measured among the patients, reflect back on the graduates, reflect back on the program or the sponsoring organization. Other outcomes might be to what extent does a sponsoring organization turn out graduates who populate underserved areas, or the distribution of specialties among graduates. I think those are examples, but this is something that's going to take some attention, and we would need the GME Council to lead that activity and to come to conclusions.
Thank you. These sounds very good to me.
Excuse me, Steve Shannon, American Association of Colleges of Osteopathic Medicine. I'm thinking about the statements regarding financing, specifically as it relates to Children's GME and the Teaching Health Center system. And if I heard you correctly, I think you're talking about rolling that funding into the CMS
Correct.
system. Does that include the current funding that's going to THCs and Children's GME being rolled into CMS? And as a second part of that, given the time it's going to take to potentially implement this, and the fact that the funding for both of those programs is in question over the next couple of years and has to be continued, does your report say anything about the continuity of those programs?
In principle, we would like to capture the money that is currently allocated to children's hospitals and the teaching center. I say that in principle because as an appropriation, there's nothing really to grab in the same way that you have in terms of entitlement. So unless it's within a budget cycle, you could capture that. You can't force the Congress to appropriate an additional amount reflecting what would have been appropriated for those functions once you get outside the budget window. This has come up once before, so let me clarify the timeline. We're talking about transitions, but we don't mean delayed start. So we would like this to start as soon as enabling legislation could be crafted and passed. The transition is what happens in year 1 and 2 and 3, and that's really the transition over the course of the next decade. So our preference would be enabling legislation be written within the next year and passed shortly thereafter, as opposed to a delay. And at the end of a decade of implementation is when we're suggesting a further reassessment to evaluate how this has been perceived to impact GME. So start as fast as you can, but to recognize that the rollout of the actual changes will occur with some phasing.
I'm Paul Rocky. I'm a scholar in residence at the Accreditation Council for Graduate Medical Education. Thank you for your report. My question deals with the references that you made twice to the 17% growth in the number of residents and fellows in the system since the balanced budget amendment capped Medicare funding. Did the committee drill down and look at that in terms of the number of graduates? Because if you do that, you'll find that we have not increased the number of graduates of core training programs, and pretty much all the growth has been in subspecialty programs and graduates of fellowships.
The number is actually since 2003. The Balanced Budget Act was 1997, so it's actually literally only the last decade or 9 years that growth. We were just noting that there seems to be some misunderstanding that growth in residency slots only occurs when additional Medicare money is funding additional slots, and that's just not the case. The fact that the growth has occurred in areas other than what might be regarded as our areas of shortages, yes, noted, not only in terms of the growth of the slots, but in terms of the general distribution that has occurred over the last couple of decades, and further emphasizes what happens when it grows for reasons other than having some directed use of public funds as to where the public needs are.
A nice natural experiment.
Yes.
We have another question from the web. This comes from Judith Powells from the University of Washington. She asks, did the committee consider broadening the responsibility for paying for GME to all payers, not just government financed?
Yes, we did. However, there was no consensus for the need for additional funds. So that changed our orientation relative to other reports that assumed there was a justification for additional funds. We worked very hard to achieve a rationale for continuing the existing amount of federal government funding, And when given alternative ways to finance the existing amount of federal funding, nothing beats Medicare in terms of predictability and certainty.
I think we have time for one more question.
Go with the American Association of Neurological Surgeons and the Congress of Neurological Surgeons. One of the things, and obviously I think reading your report, maybe this will be evident, but with the shift in focus away from perhaps the academic medical centers and the current way training is done in this country, I think there's some concern that the infrastructure that's necessary to support the education system could be caught in this ever-shifting sand, depending on where those dollars go, how stable the funding is going to be, and the like. I mean, for neurosurgery residency, it's a minimum of 7 years, and then typically there's 1 or 2 years of fellowship after that. The enterprise to educate and adequately train neurosurgeons to meet all the ACGME's milestones and other requirements to make sure that they're adequately trained before going out in practice. And that's not an insignificant investment in infrastructure to be able to do that. And I think that, having of course not read the report yet, that our folks are going to be a little concerned that whether it's taking money away from the institutions that are currently, or shifting the capability of that money to travel with perhaps the resident or go to non-academic medical centers where the current GME enterprise resides, at least for some of this, and will that funding be following that full residency training, and will we be diluting it? I mean, I think those are just some of the concerns that come to our mind right now, and just curious what the committee might have to say about that.
Well, we would
those
recommend,
points, perhaps.
would recommend that another group consider whether or not the current amount of time that is devoted to training for specialists or super specialists is appropriate. So I'm not going to comment on the current requirements. What we are concerned about is that the generation of specialists that was noted that has been going on in the absence of additional funding seems to be very robust in the area of specialists. The area and the infrastructure which seems to be lagging behind is on some of the less highly compensated under current reimbursement systems specialty areas, and that the places that people will ultimately practice are too infrequently the sponsoring organizations receiving funding. By definition, since we're not increasing more funds into the system, any kind of shifts will mean lesser to some of the institutional settings as a guarantee. One of the important principles that we believe we're recommending, because we are not trying to take money out of the system, but rather redistribute it, is that groups that are currently involved in graduate medical education, if anything, have a head start on trying to come up with innovative ideas and programs to use to approach the transformation fund, and that they are able to propose ways to keep monies for important funding strategies. It's just not going to be guaranteed in the way it has been in the past. So we hope there'll be some changes in terms of the distribution, since there was skepticism that the current distribution was particularly optimal. But that really was not for us to decide. It was to have it be more innovative and performance-focused than exists now, and that groups that would not be assured exactly, or even not precisely the same amounts of funding have opportunities to propose programs to have the funding be very similar or greater than they would have had in the past.
But you're not concerned about a fragmentation, perhaps, of the system as it sort of maybe expands throughout in a budget-neutral fashion across the country that may not produce stability over time, despite, acknowledging some of those comments.
I wanted to make a comment that sponsoring organizations in many instances remain as teaching hospitals. Right. So the academic medical centers now are sponsoring organizations, and in many instances will remain sponsoring organizations. There are other organizations which are sponsor residency programs but now do not receive funding, such as federally qualified health centers, clinics, universities that may receive the funding, but we recognize that training programs take place in a variety of settings, and many take place and are pretty dependent on teaching hospitals. So the idea was not to destabilize that. The committee's report emphasizes, as Dr. Walensky has talked about, the need for trying to transition over time, not to destabilize the current system. We recognize the vulnerability of funding streams that people have counted on for 50 years or more. And so we have suggested the phase-in to assure that there is as little destabilization in the short term as possible.
Thank you.
Thank you all very much for coming and for watching on the webcast. Just want to remind you that this afternoon at 1:30 there will be a panel discussion which will also be webcast. And again, you can find the report and other materials at www.nationalacademies.org or www.iom.edu. Thank you.